Good afternoon, everyone. It is my great pleasure to welcome Dr. Sandeep Laroia, and he is Associate Professor of Radiology and Oncology at University of Iowa, USA. And he has specially come here to speak on the topic endovascular management of hemoptysis, a review. And he is the Vice Chair of Department of Radiology at the University of Iowa, and he has a vast experience of cardiovascular and oncology interventions. His special interests include specialization in embolization, and he is also the founder president of Juggernaut Life Sciences, a medical device company based in USA. He has authored many papers and is nominated in the top 10% of the US physicians. And he has also been a part of Cardiomergen since more than a decade, and he has given various talks before this also. And I'm very much thankful to Dr. Sandeep, and I hope you will enjoy giving this talk today.
Wonderful talk. We have lost one or two patients where we were not able to get. Young patient with dengue and everything, septic shock and everything. He improved, but later on started bleeding.
Right.
No, 10 minutes पहले की बात है सर, 9 years back. जब वो लगता था कि he will not survive now, he survived. At the end of the day, when he was about to discharge, before 1 day before,
massive.
We tried with. हाँ नहीं हम लोगों ने फिर सर से हेल्प ली थी, ब्रोंकियल आर्टरी में किया था सर, तो हम लोग मिला कुछ नहीं था उसमें. तो somehow I don't know, maybe it was from the trachea itself or something.
Right.
We tried with to see localize the bleed from the bronchoscope also.
Right. The main challenge is technological. You can't see.
We can't see.
That's the main challenge, Yeah.
So I had a small query. Suppose an OPD patient comes to you with a history of hemoptysis, and that's like 4-5 episodes in the last 4-5 days.
Right.
And you do a CT scan, you find some lesion over there. So do you recommend bronchial artery angiography in such patients? Because many times these patients are bleeding on and off.
Right.
If you don't have an actual bleed happening during the angiography, you don't see anything.
Yeah.
So how do we give them some statics and they stop, and then they again come after another 1 month.
Right.
So these things keep happening, and
Right.
You have a lesion, but they're not bleeding. And then
Right. So we covered that point. Number one, on angiography you won't see anything. But on CT scan, if the measurement is more than 2 millimeters, and which side is bleeding, I typically prophylactically embolize them.
Okay.
So I go back.
Normal vessel, normal size.
Yeah. So if it's about 2 millimeters and they have history of hemoptysis, and you are sure it's coming from the left side and that artery is big, you just embolize that. So in many cancer patients, because TB is rare but cancer is very common, so we get these patients all the time. So typically that's our protocol. So we know that they are going to bleed again, we just embolize them.
So basically in India the problem is like in esophageal varices now. If somebody is alcoholic, you have to do a serial endoscopy every 2 years or 1 year down the line, depending upon severity of the alcohol. तो उसमें endoscopy लोग they are not going for the endoscopy.
Right.
So here if you tell them कि this is 2 mm and we should okay, तो कहता है liver bleed आएगा तो we'll see.
That's the biggest that's the biggest problem.
और तो हमने बोला ठीक है भाई देखेंगे.
Right.
जब तक वो मरी नहीं हो रही थी तो
Right.
Once they are in emergency only then we'll go for
Right. And
there is free for admission with hemoptysis sometimes.
Right. And I think that's where the community education comes, that we need to tell these guys, आज तो रुक गई है, लेकिन 3 महीने बाद फिर होगी, and we may not be able to do anything.
नोट्स लिख दो कि ब्लीडिंग हो रही है, हो सकती है, जाना है, रिस्क पे चले जाओ.
So education, some patients will still be like that, कि जब होगा तभी आएंगे. So that problem is there. That problem.
In case you remember from your experience, the one you told with spinal ischemia.
Right.
Anticoagulation just after embolization, how did you went about it?
So now we
the risk of bleeding again.
Right. So it's a very fine line. So typically we start with spinal tap. We try to reduce the pressure. We give steroids. And about 75% of cases they improve. Typically we don't start anticoagulation right away. So we wait 24 hours, 36 hours. If no improvement, then we go for that.
So that is the time.
That is the time.
You buy time and
Buy time. Right. So we almost never we start, heparin right away.
Right.
Yeah, right.
My question was like in emergency situations when a patient comes with hemoptysis and you told most of the patient die because of asphyxia.
Asphyxia.
And if you are lucky enough to localize in CT that this side is bleeding,
Right.
is there any role of separating the lung?
Yeah.
You separate?
We separate the lung. Almost always we separate the lung. Some patients will come like cystic fibrosis. So they get bleed. Every 6 months or so, and we know which side is bleeding. Pediatric patients. So those patients they need protection of the lung for sure. Okay. Older patients who are well compensated, sometimes we do it quickly because in experienced hands, it's very quick procedure. You can be in and out in about 45 minutes, But if you anticipate that there is going to be problem in localizing, for example, 80-year-old patient. So now the aorta is full of plaques, and you are trying to find, bronchial artery. So it's going to take some time. In those cases, we do the protection. Yeah,
Like
always.
our setup, we can buy some time by
Right.
separating the lung.
Separate. Yeah. So I think that's crucial. Yeah.
So you people are putting double lumen tube or bronchial purpose?
Double lumen tube. Yeah. Again, it's an aesthetic, choice. What they want to do, but typically that's the
Thank you very much, Dr. Sandeep.
Thank you.
I would like to share a few interesting cases. I think we'll just discuss about
Okay.
them. Like you mentioned about separation of the lung. We started a technique called physiological lung exclusion.
Okay.
That is published in a European journal also. And then we published one article in the Asian Annals. So we had a patient, he was 82-year-old and he had massive hemoptysis, and on angiogram there was a pulmonary artery aneurysm.
Okay.
So that was arising just beyond the region of the right upper lobe branch. And it was dissecting into the lung, and it had already ruptured into the lung, and it was bleeding heavily. So the cardiologist that time I was in Fortis, and they thought that the origin is too wide for anything to be put to block it.
Yeah.
So what we did was that we took the patient for a thoracotomy, and on table it was very difficult to identify the pulmonary artery because there was the blood had dissected all across.
Right.
So what we did was that we ligated the pulmonary artery just beyond the region of the upper lobe branch.
Okay.
And we also blocked the bronchus.
Okay.
And after that the bleeding also stopped and the patient also recovered. So we have been using that technique for those patients who have massive hemoptysis, and sometimes in tuberculosis also when the entire lung is stuck. So if you can't take out the lung, because if you try to take out the lung, it keeps on bleeding all around. And sometimes you may lose the patient on tuberculosis. So we can block the artery, and if we block the
Bronchus also. Okay.
So that we devised that technique as a physiological exclusion of that part of the lung.
Right. Yeah, basically both the pedicles are gone.
So we have done around 5-6 such
Yeah.
cases.
Okay.
And then I'll share Dr. Sudhir, he's the director of cardiology here, and we had very interesting cases. Last year, one of them was post-COVID, and that was a mother of one of doctor only, and she had dyspnea, and saturation started coming low. So when X-ray was done, so there was a huge opacity on the left side, and then the pulmonary angiogram showed that there was a AVM. So it was on the left side, and it was a huge communication. So then Dr. Sudhir, he thought of I think you put a AST test.
So actually, it was a very rare anomaly. It's a LPA to LA.
Okay. Okay, so massive shunt, huh?
Right. Likely to be congenital, but
Right.
only come to the fore because of the COVID.
Right.
And in the literature, we have not found another case.
Acha.
It happens in children sometimes,
Mm-hmm.
not in adults.
Right.
But it was a massive thing.
Okay.
So we thought of putting coils and all, but
Right.
the flow was so torrential.
Right.
We knew that they are going to migrate to the from there into systemic.
Mm-hmm.
What we did was we took an ASD device,
Okay.
right? We just pushed it inside and just pulled it.
Okay.
So it became like
Right.
and it totally occluded.
Well, okay. Yeah, I don't know if we have a case. Yeah, we did almost similar thing, we used an Hemoptysis
Yes.
plug,
Yeah.
Right. So we used an Hemoptysis plug, and that sometimes. So you see, so there is a massive.
Yeah.
So this is after Swan-Ganz actually, So the pulmonary artery aneurysm is so big, And what to do with these cases, So in this case, I don't have that, but we put it Swan-Ganz,
Right.
and we just filled it up,
Right.
Right. So, and then, these are, so this is Behçet disease case actually. So in Behçet disease, again, the pulmonary artery aneurysms happen, because of inflammation, and they can get very big, So now again, the problem is if you put a smaller coil, that will flow back into the left side, So in this case, we actually started a coiling here. So we created a sort of rope,
Right.
scaffolding, and on that rope we attached this bigger plug, so it won't go away. So, but these are challenging cases, yeah. So.
You had the child also.
And we had another interesting case. So Dr. Sudhir, he referred the case to us that patient had AVM, 10-year-old child, and it was a huge AVM on the right lower lobe.
Okay.
And there were too many arteries supplying that AVM, so it was not possible. Like we had a discussion, and Dr. Sudhir thought that
There were multiple arteries.
they were too big and too tortuous arteries,
Right.
so it was not possible to embolize. So then we saw the CT and we did the 3D reconstruction, and we tried to figure out from where the main supply is coming. So there were like large arteries, tortuous ones, and one was covering the superior surface of the main AVM, and one of them it was coming on the inferior, and there were multiple from all around. So we thought that we'll do a surgical resection. So we did a VATS, and then we tried with the bipolar cautery that if we can isolate the big arteries, then maybe we can separate the aneurysm part. But when we were trying to touch, like they were so tortuous and vascular that it was torrentially bleeding. So what we did was that because we had done the 3D reconstruction, so I had a basic idea in my mind that what is the location of the lower lobe pulmonary artery from each of them. So then we did a segmental section in which we used a linear cutter. So we just made sure that we don't cut the pulmonary artery supplying the lower lobe.
Right.
And,
but strip kind of.
But we just removed that segment, and all the feeding vessel they got clipped. So after that, like patient had very dramatic recovery, and before surgery the patient had a saturation of around 80%, and there was frank clubbing and cyanosis, and within couple of weeks, like the saturation became more than 95, and the clubbing also started vanishing in the follow-up. Like he has been coming for now almost 3-4 months, I think more than that, 6 months, and that cyanosis has vanished.
So that means shunting is gone. And
no, that's X-ray good. Comes clear now.
Right.
Another interesting case was that we were referred a case which had a huge kind of a aneurysm type of a swelling in the right lower lobe. So on pulmonary angiogram, like we saw that the blood was collecting, but were not able to localize like from where it was coming. But few feeding vessels like we could see, and when we opened up through video assisted only, so we tried to aspirate that. We aspirated 20 ml and again it filled up. We aspirated another 20, again it filled up. So it was not possible to like go around it because it was huge, like
Big.
almost a little smaller than a football. And then we saw the feeding vessel. There was some vessel coming from below the diaphragm also.
Yes.
So we first ligated them.
Right.
And then we went all around and ligated all the
Right.
feeding vessels and removed.
Right.
And then we sent for this histopathology.
Right.
And we were surprised that it came as a tubercular. So maybe it was a giant Rasmussen gland.
Right.
So we never imagined.
Yeah,
that
it could be Rasmussen, but with sequestered lung, sequestered lung. So supply is coming from below,
And it was like immediately filling.
Right. So it was sequestered lung, and because of that, TB settled there. Yeah. Right. Interesting. Yeah.